شكرا. Thank you kindly, Ustad Adnan, for the kind welcome. احطها هنا حتى اشوف انا التايم، لان انا اخاف من اظل انا هيك مثل البعبع على موضوع التايم، خاف واحد هم الله يسوي لي بو. Right, welcome to the second session. We have this session, and then followed by this will be the COPD session, and inshallah lunch afterwards. Hopefully you're enjoying the day so far. So if everybody can just focus on the slides, please. So what we'll be talking about is the undiagnosed pleural effusion. The British Thoracic Society, free access, 2023, has the full detailed guidelines and also a summary guideline that would be helpful. So a brief introduction, imaging in terms of recommendation of do's and don'ts. Some of it will overlap, so I will skip the ones so that I don't repeat what Ehab had just discussed. Diagnostic accuracy of tests in terms of enhancing and streamlining the pathway for patients to try and get the diagnosis first time with the least invasive measures. Image-guided intervention, some comments about that, pleural biopsy. And basically what I'm going to do is the BTS undiagnosed pleural effusion part summarized in 20 minutes. I added this slide to Ehab's surprise, which takes me back in the time to the Ehab. I added it because for two reasons. Ehab mentioned about safety of imaging. So guidelines are helpful because they guide you. They guide you to ensure that you're providing, after you've formulated the differential, you've achieved a definitive diagnosis, they provide you with guidance into how to treat your patient based on the latest evidence available. But it is guidance. And there are times when patients don't necessarily fit with guidance. That's one. That's one aspect that preserves patient safety. Another aspect is the stuff, so that's the things that we're going to talk about, the guideline. Another aspect that I think is I'm passionate about and is close to my heart. I remember back in the day, من إيهاب كان بعده baby SHO. وبعدك شباب كنت انت والله الله يذكره بالخير. And that's Helen Meinel, a feisty consultant in pharmacists. So what happened was there was a case where ماذا ذكرها إيهاب لا لا, but basically a patient was presented with pneumothorax, we thought, and then he had a chest drain inserted, but it wasn't. So when I looked at the x-ray, the first x-ray, I said, this is not a pneumothorax, it's a bulla. To me, it's clearly a bulla. Clearly, to the emergency department, it wasn't a bulla. Then the patient, I think, came to harm. Not only it was refractory, he stayed in hospital, he developed hospital-acquired infection and passed away at the end. What led to this clinical reflective forum was, I remember the self-deprecation, self-flagellation, the depression that ensued for that trainee. And I always say, as long as you try your best and you're not a psychopath, then everything's fine. Don't beat yourself up about it. فأنا وإيهاب ووضح الله يذكره بالخير وهالمايل الله يذكرها بالخير, we created a platform that allows us to focus on guidelines, make sure they're updated, make sure our trainees know about guidelines, but also any case that has had a complication, we locked a lot of this Facebook, معقد الموضوع, but we locked a lot of the Facebook so that it's patient friendly, anonymized, etc. And then we present these cases ونسأل the trainees. 60%, 70%, 80% of the trainees would do exactly the same as that trainee did in AD, thinking that it was a pneumothorax rather than a bulla, and they would have, and I give them options. Option one, insert chest drain, etc. So the trainee in question felt better. So it's not just me who's rubbish. It's not just me who's inexperienced. And then we had other cases that we had. I don't think it's still going, but the concept is of guidelines is a lot of it is to make sure that we do the best by our patients. And that's why I would strongly recommend people in the specialist field of respiratory medicine or any branches of medicine to keep an eye on guidelines, particularly for common disorders that they encounter in their daily practice. So if you're an internist and you're seeing a lot of systemic hypertension, diabetes, etc., you need to be on the ball. If you're a respiratory physician with a lot of intervention, you need to be on the ball. Pleural effusions, extremely common to the extent, particularly in places like Iraq, where it's a problem for the internist, never mind the respiratory physician, never mind the pleural physician. There are more than 60 recognized causes of pleural effusion. Some are local, disease within the pleura. Some are related to the adjacent lung. Some are systemic, and that would include some organ dysfunction within the lung or otherwise. And some drugs can cause it, again, the systemic route. This is not for you guys to read at all. It's a busy slide, of course. It's just to highlight, again, the BTS guidelines 2023. These people contribute to a lot more of this compared to me nowadays anyway, which is great. And we need people like Stephen, Ehab, and others in the European Respiratory Society and the BTS. So they do all the hard work and the academics so that to make our lives easier to answer the unanswered questions when we have patients. Lots of flow charts, lots of things, quick to refer to, really helpful. I know it sounds very old-fashioned, but the more I grow younger as a physician, the more I realize this is true. History and examination. In all honesty, one of the reasons, and I remember when we used to discuss this, myself, Sad Abdul Hamid, and many others, that's why we really find it important to amalgamate general medicine with respiratory, because you need very strong foundations to be able to become a brilliant diagnostician. You need that clinical acumen. And when it comes to respiratory disease and when it comes to pleural effusion, the history is crucial, and the examination too. The drug history, always in italics and bold font with an exclamation mark. And sometimes we can be a bit lazy. Drugs, there's pneumotox, there's lots and lots of sources out there. So if you're left with an undiagnosed pleural effusion, but you haven't really looked at what drugs can cause it, that's just lazy and unfortunate. One of the things that I've put in here, including exudative effusions, is TKI, tyrosine kinase inhibitors. So there's like a long list of drugs historically in my day when I was a trainee that cause pleural effusions, but TKIs in particular, and it can be compounded by people that need TKIs as treatment because of the effect it has on B and T cells within the pleural surface, leading to a lymphocyte predominant exudative effusion within that region. So it's not uncommon to find it with TKIs. So when patients are taking TKIs and they develop a pleural effusion, don't assume necessarily that it's systemic related to the underlying illness. It could be related to the drug itself. Occupation, again, in italics, in bold font with an exclamation mark, always. And what I mean by always, when you're busy in clinic, what do you do for a living? Masush. Kasib. What does that mean? Nothing. Sometimes when I have my trainees, for example, and they think, does he have time for this? It's just because it's so important. What did you do when you left school? Did you work before school بالنسبة للعراق? حبايبنا, not necessarily in the context of pleural disease, دخنين لا. خبزين قبل إيه. على المطال biofuels with COPD as an example. So pleural disease is so وين كنت عسكري تشتغل شو تسوي اشرح لي. So some of them in the army, a lot of people this era who present pleural effusion would have been in the army. شو تسوي؟ ميكانيك تبدل بريكات الديسك مال السيارة؟ اي طبعا. وعليك كانت المسؤولية؟ اي. هاي بعد positive for asbestos exposure. خصوصا ذاك الوقت with the military مالتهم كان كل البريك باس بها asbestos. So just to highlight the point, يرادلها تركيز. TUS, thoracic ultrasound, is literally an extension of the physician's arm صار. وبالنسبه لمساعد سالف الدكتور احمد يوسف كم واحد على هاي سمول بروبز هسه ويا ادفانسز مال تكنولوجي صدق انا احنا نشتغل سويا بنفس المركز فالقاه يعني شلون انا شايل السماعه احمد يفتح هو البروب، كل ما شفنا مريض حطه هنا، شوف عم قلت لك عارف. وصدق هي يوسفول يعني، حتى ذاك اليوم مو شفنا هذا pedunculate، يعني الريزولوشن مالته فظيع. ف it is genuinely the extension of the physician's arm. When I was a lad, John Winter الله يذكره بالخير استاذي, I remember in 2001 or 2 they just started using ultrasound. I'm not joking, the ultrasound machine was as big as this لهنا, and the depth heavy. So, and it was very easy for John Winter, he's my boss. Mudher, ultrasound. That's like an hour of me unplugging it, pushing it into the patient corridor, and now we have them as a hand device. So we've moved on. So there's no excuse not to use ultrasound when we're now doing TAPS or thoracentesis. The diagnostic rate is much better. It also helps you understand the size of the effusion, which is also helpful. And some of the dynamic component when you put the ultrasound, which Professor Najib Rahman mentioned earlier, that really helps to know whether there is diaphragmatic dysfunction or not, is the lower lobe totally collapsed. That actually makes a big difference. And safety, when you use ultrasounds, I remember, so this was in Dundee, Ihab won't remember this. One of my colleagues, Dr. Ali Dabbagh, Allah يذكره بالخير, he's from Mosul, but we work together in Tayside. So when we introduced the ultrasounds and stuff, he said, Mudher هذا شنو الجديد الالتراساوند؟ راويني يا جون وينتر خبصنا به. جبنا المشين هاي هسه قلت له جيتي علي هاي السالفه. حطيناه, we put the ultrasound there. We thought it was a massive effusion. And then he randomly, subhanallah, asked me, he said, what's that button for? قلت له هذا الدوبلر. ذاك الوقت we just started to use ultrasound. And there was the aortic aneurysm that we were just about to drain. قلت له دكتور علي عليك خلنا نوقف شويه. اسحب ايدك شويه خلي الانيوريزم هذا احنا ما ندخل فيه. بس والله كان شكله كان effusion بالاكس راي. So things have moved on. هاي الكونتراست arterial phase in the past when they did it between the ribs highlights احنا دوم بالكتب make sure you're above the rib. هو واحد مرات هالقد المريض سمين فانك انت تفيل the rib زين هيك وتضغط ف to actually find and put the drain just above the rib is actually quite difficult. And I think that's when you're thinking, that's why they introduced a safe triangle. I think with a small needle and people not taking clopidogrel or anticoagulants, etc., it's probably okay. But when you're looking at bigger drains, including 14 French, 16 French, multi-fenestrated drains, it's really helpful to go there first time and not hit the intercostal artery. If طبعا هاي الاف انا حاطها unsafe quote unquote, مثلا unsafe شنو؟ هي موجوده بالجايد لاينز. شنو مثلا خاف المريض طلع حامل مثلا شنو unsafe? How is thoracic ultrasound unsafe? I think they mean unsafe in terms of the image is not clear, it technically might be a bit difficult, all that stuff. I know انا شويه جوك, تعرفني انا ما قاعد راحه ها. Operator dependent, etc. Yeah, absolutely. There's no sterile stuff and you're like, do you know what, I'm just going to mark it. And then the patient goes for a shower and comes back and they're not in the same position. All that. If it is unsafe, CT is useful. CT cap, chest, abdomen, pelvis. When you've got undiagnosed pleural effusion, we're talking adults, unilateral, exudative. CT thorax venous phase, if you're not suspecting malignancy. So if the patient doesn't have stigmata of malignancy, no clubbing, no supraclavicular lymphadenopathy, not losing weight, venous phase CT only, is probably enough. If it's too small to sample, or the patient declines, اللي هو consent, هو ناس لا 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 ما أريد, there are common problems that you should consider. PTE, pulmonary thromboembolism, mycobacterial tuberculosis, lymphoma, IgG4 disease, and chronic heart failure, refractory. These are the ones when you've got effusions or you're not sure about the safety of the patient, etc., consider them actively. And in such cases, doing an interval scan is reasonable. In a small effusion, they don't have stigmata of malignancy, and you've done the venous phase and it looks okay. Interval scan is fine, accepted. I think sometimes our people, particularly, قالوا لي ما يعصدر, يخافون. They get scared when they hear that word. مرات هو thickening anyway مو ماي مرات bilateral systemic. But it's interesting how like a collection of fluid on the lung outside the lung in the UK to there over there people accept it. It's not necessarily that's it the end. Whereas in Iraq if you say اكو ماي على صدري that's cancer. And because of the culture that no they're hiding it from me. Yeah, but ما بيك شيء. For a small effusion interval scan, it doesn't usually suffice. They'll see about 6 other doctors. Then, and then somebody will attempt the pleural tap, and then they'll end up with a pneumothorax. So when we look at optimal methods in terms of diagnosing, I would say plain chest radiograph, still, although two-dimensional structure, brilliant. CT, we mentioned. Thoracic ultrasound, we mentioned. PET CT in the context of malignancy, and malignancy that you're thinking maybe radical options might be available for the patient. But as Ihab said earlier, it's still, a lot of it is investigational when it comes to pleural disease, and it should not be used in infection because then the true positive rate is so low, it's not worth it. An MRI scan, I think, it shows beautiful pleura, but it's still investigation. But it's just beautiful pictures to look at, but I'm not sure it adds more than that. Anyway, a bit cynical. The diagnostic accuracy of radiology. So if you have circumferential pleural thickening, suspect underlying malignancy. If there's nodularity, particularly in the mediastinal surface, suspect malignancy. And when you look at the diagnostic accuracy there on the right, based on evidence and the number of studies, that's 10 studies together when you put them all together. Thoracic ultrasound in terms of the pool sensitivity, i.e. the true positive rate, or specificity, i.e. the true negative rate. فمثلا specificity, a very good negative predictive value is D dimer. صح? Useful if negative, useless almost if positive. هيك معناها. For TUS 0.80, 0.9, يعني you're looking at 0.80 plus in terms of both sensitivity and specificity. Well, alhamdulillah, I think one of the things that might have actually attracted him to respiratory medicine is there's a lot of physics with it. And there's a lot of stuff that you can see. Alhamdulillah, I can still do rheumatology, endocrine, etc. But I just, all these numbers and stuff, and you have to second guess, and that hyponatremia just puts me off. Pleural infection, Ihab will talk about that in detail in his talk, inshallah. One of the things that you have to watch out for, and according to the guidelines, is that there's some overlap with malignant features. You can get coexisting hem infection. So not only infection and malignancy can look the same, but you can have them both. Or MTB, particularly in an endemic area like Iraq, Mycobacterial tuberculosis can mimic malignancy. شلون? It can mimic malignancy because it can cause pleural thickening, more than 1 centimeter, which is usually suspicious. Complex septations of thoracic ultrasound, TB commonly causes that. It's lymphocyte rich, so the other differential is heart failure, lymphoproliferative disorder. And there's no chest wall invasion with it, apart from in infections, empyema necessitatis, which is rare, but you can get stuff like Staph aureus in particular, that sometimes, particularly if it's, or some other gas-forming organisms that can actually invade the chest wall, but it's infection. You still have to biopsy it, of course, to prove that it is empyema necessitatis. So the pleural infection, when you're suspecting it, you look at the lenticular configuration there, clearly on the picture. You look at the split pleural sign, so you can see it there on the how it's split. هاي من is a nice one. شوفون شلون كانها البلورا كان هيك واحد قاصها بالنص مثل هاي الغصن. هيك كانها split. That's very common in infection. You get increased density of the extrapleural fat, and you can measure this. You get presence of pulmonary consolidation next to it, again, that makes you suspicious. Usually if I see this, ويما اكو pulmonary consolidation without the circumstantial thickening, without loss of volume, correlate with patient's history, I think probably infection, but needs follow-up. There are non-infective causes as well. مثلا rheumatoid arthritis is common, Dressler, PTE, pulmonary thromboembolism, and benign asbestos disease. It's not that exciting when you see, if you see an effusion and it's not that exciting, likely benign or likely non-infective. But we'll see that effusion that you see in that CT, واحد يشوفه ويدور على شيء ثاني, other features, thickening منه, fat deposit يمن البلورا, all of these things. It's not that exciting. It's just an effusion. It's unilateral. Then you think probably I need to think about these things, and it's probably benign. It's quite smooth. And it's unusual in non-infective causes, which of course is a benign entity as well, that you get any mediastinal involvement. Sometimes you get pleuroparenchymal bands that you can see there on the left side image that come from the pleura. That again indicates non-infective causes that can include some of the above there as well. Ancillary imaging. So when you're suspecting cases that are non-infective, not malignant, think about what other tests can I do to try and home in. So is there calcium pleural plaques? Think asbestos. Is there other features of pulmonary congestion, upper venous diversion, for example, blunting of the cholephonic angles on both sides, bilateral always, all the other features that you guys will know, and maybe check for pro-BNP, for example. Post-cardiac surgery, is there a temporal relationship? Have they had cardiac surgery? It's usually on the left. Traumatic, is there a history of trauma? Hairline rib fractures surprisingly cause hemothorax, and they're not always easy to observe in a plain chest radiograph. So they cause problems. And then, of course, other things like cirrhosis, adnexal masses, etc. But I'm not going to talk about them in detail because I believe Stephen will mention some of them, inshallah. So when we look at image-guided intervention versus non-image-guided intervention, thoracentesis, as we said, is a key intervention, not only as a diagnosis, but also therapeutic, between 500 to 1,500 mils. If the patient derives benefit, that's usually a good indication for it. It should be real time. مثل مساعة إيهاب, when he showed you how the needle's going through, I must admit and hold my hand up and admit to being a dinosaur still and lazy. فمرات أنا put by the bedside thoracic ultrasound, لا تتحرك ضل هيجي على ما أحضر. And I don't usually go wrong, but I need to, شنو احنا نقول, لما تقولون ما لا تفعلون كبر مقتا عند الله. فإن شاء الله لا نطبقها صح, خصوصا بالألتراساوند مع أحمد, ناخذه منه بوقة ونضل نسوي. And it's different from bedside thoracic ultrasound marking because you can actually miss and cause a lot of problems. The evidence, يعني, in terms of length of stay, when you compare image-guided versus non-guided, length of stay, I think a lot of that data is based on Western hospitals. احنا ما عندنا length of stay بالhospital, احنا أكثرهم ambulatory anyway. Success of obtaining pleural fluid, definitely better. Increased success with image-guided intervention. Need for another procedure is not being compared. Complications, not that much difference with either. Pneumothorax risk, طبعا less risk with image-guided. Mortality, alhamdulillah, not reported. I remember one of my SHOs, Mudher, ironically, he's a hepatologist. So we did that crime. Yeah, did the Abraham biopsy? Who showed the Abraham biopsy? You. For the Abraham pleural biopsy, he said, Mudher, teach me how to do the Abraham pleural biopsy. So and the patient bled. There was blood gushing out of the Abraham pleural biopsy. So he was panicking. We finished. The patient was okay, stabilized. خليها سكتة. No, that's a probity issue. لا تخليها سكتة. بعدين in the pathology mortal MDT من كملوا الكيس قالوا normal liver. واحنا منتظرين نشوف البلورال بايبسي قالوا normal liver. سبحان الله هو صار hepatologist. أنا دوما أذكر بهاي القصة طبعا. In terms of containers and volume of a pleural fluid sample, هواي مرات يسألوني, they always ask me, وحدة, اثنين, أربعة. I always say bring plenty. If you really want to give yourself a good chance of diagnosing malignancy via cytology, you need at least, I think, 50 mils. The cytologists complain, but I'm like, I'm sorry, but that's you need to increase human resource, but that's what it is. But at least 25 to 50, you need a good, and there's consensus with that. And you see, we all see it, I think. The more volume you send, better. Plain and blood culture bottles, if suspecting infection, again, consensus opinion, rather than a lot of studies. But if it's small volume, sometimes you get small volume. I would rather you put it in the culture bottle in favor of the white tops. And that's what the BTS guidelines say as well. So when it comes to biomarkers, pleural fluid biomarkers do not provide improved sensitivity for all these tumor markers, but pleural fluid, don't bother. It'll just confuse the issue. Interestingly, pleural fluid adenosine deaminase is really helpful in the context of suspected TB if you get it from the pleural fluid, but it's not readily available. The thing that is, but it's expensive, particularly if it's out of pocket, is gamma interferon, which is helpful in diagnosing pleuritis pleural TB, which is extrapulmonary, and not only useless, can potentially be harmful because it might lead to a misdiagnosis and active pulmonary tuberculosis. Okay, so this is for pleurisy, not for pulmonary TB. And pleural fluid NT-proBNP, low evidence. I think it's helpful. Pleural fluid ANA, if you're thinking something like lupus, is helpful as well. So in terms of recommendations, if you have, you should investigate further. So if you have a sterile, cytology negative exudate, tissue sampling is the gold standard. Gabelchan Abraham pleural biopsy, alhamdulillah, we're finished with that. And it's specifically if we're suspecting malignancy or suspecting pleural MTB. And that's consensus opinion. I think I mentioned some of these, yep. And so I'm not going to talk about the details of what I don't call it medical thoracoscopy because it's a surgical procedure. That's what everybody calls it. But I say thoracoscopy under conscious sedation. I think that's probably, or pleuroscopy under conscious sedation. I think that's probably the most accurate way of describing it. It has revolutionized tissue sampling in pleural diseases in those who are cytology negative, sterile, exudative pleural effusion. Those who've done pleuroscopy, alhamdulillah, we're starting to do it more and more in Iraq. We've seen the benefit that we get because you see everything directly and it solves the issue as well. The diagnostic accuracy of pleural biopsy, I'll just mention a couple of them. In the old days, we used to do the rigid one, and this is the semi-rigid that we have in Iraq predominantly. There's no difference in terms of pleural biopsy accuracy based on all the evidence that we've seen. And there's definitely a higher diagnostic yield against blind pleural biopsy. And I think that's just obvious. There's the evidence to show that as well in the BTS guidelines. So if clinically indicated, consensus opinion, they should undergo thoracoscopy, and blind pleural biopsy, Ihab has already mentioned, should not be conducted because now I believe it's a crime against humanity. ونحاولك على الشرطة خابر الشرطة إذا شوف واحد بيده pleural biopsy. Take home slide. Unilateral pleural exudative pleural effusions in adults. Thorough clinical assessment is a must. History examination مثل ما حكينا. Thoracic ultrasound is the extension of the physician's arm. بالذات إذا اسمك دكتور أحمد يوسف. Give careful thought to image modalities, including ancillary testing, كلش يساعد, depending on suspected causes to allow streamlined diagnostic accuracy. Thoracoscopy is the gold standard for cytology negative sterile exudative pleural fluid. And these are the references. You're welcome to study them. I definitely expect from our trainees and board trainees in respiratory medicine to know common diseases and all the guidelines. And so that they don't blame us. مو بالامتحانات استاذ بالامتحان حتى ما حد يحكي بعدنا قلنا لهم والله حتى ما حد يحكي نحن expecting people to know it very well لان احنا تعبنا حتى الواحد يتعب على ذن الجايدلاينز and you see some of the figures sitting next to us etc contributing some of these guidelines وشكرا جزيلا